Preeclampsia is a disease specifically associated with pregnancy. It usually occurs in the second half of pregnancy and is characterized by hypertension and proteinuria. The presence of pedal edema or excessive weight gain may also be a feature of preeclampsia. Blood pressure monitoring every 4 hours together with daily weighing of the patient are essential in the management of preeclampsia alongside the recommended investigations. While blood pressure reduction is essential, lowering the blood pressure below 140/90 millimeters mercury may cause fetal distress and should be avoided. So the causes are primigravidi. The cause is unknown, but the disease is more commonly associated with primigravidi, maternal age, especially women less than 18 years or more than 35 years, multiple pregnancies, hydatidform, medical disorders like polycystic ovaries, chronic hypertension, diabetes mellitus, kidney disorders, first pregnancy with a new partner, previous history of preeclampsia, family history of preeclampsia. Main symptoms are patients with preeclampsia are often asymptomatic. Swollen feet. The signs that are usually elicited for mild cases: systolic blood pressure between 140 and 159 millimeters mercury, diastolic blood pressure between 90 and 109 millimeters mercury, proteinuria of +1 or +2. Also, pedal edema. For severe cases, the signs are systolic blood pressure of 160 millimeters mercury or higher, diastolic blood pressure of 110 millimeters mercury or higher, proteinuria of 3 plus or 4 plus, also pedal or generalized edema. The investigations: FBC, serum uric acid, BE creatinine, urinalysis and culture, liver function test, random blood glucose, daily assessment of urine proteins, ultrasound scan for close fetal growth monitoring. Then the main treatment objectives are to reduce elevated blood pressure but not less than 140/90 millimeters mercury, to prolong the pregnancy as much as possible to allow the fetus to grow and to mature for delivery, to prevent fetal distress, to prevent or treat any complications that may arise, also to prevent eclampsia. Non-pharmacological treatment: to admit for rest if possible and encourage patients to lie on their sides to avoid supine hypotension. Pharmacological treatment: for mild preeclampsia, there is no need for drug treatment of hypertension unless the BP rises above 150 millimeters mercury systolic or 100 millimeters mercury diastolic, or the patient becomes symptomatic of imminent eclampsia. With that, you give metaldopa oral 250 to 500 milligrams 8 to 12 hourly with a maximum dosage of 2 grams per day, or nifedipine retard oral 10 to 40 milligrams 12 hourly, or nifedipine slow release oral 30 to 60 milligrams daily.